Can everyone hear me? Okay. So, I apologize. I had a bout with some mystery illness last week, and my voice has not made a full recovery. But hopefully, if I get hard to hear, someone just raise their hand and I'll speak up a little bit more. So today, I really appreciate everyone coming here. I plan to try to take you through just an abstract journey through my experiences in trying to model immune signals in the composite of vascularized, in the context of vascularized composite allotransplantation and VCA. And a lot of you probably haven't really heard of VCA before, and that wouldn't be terribly surprising, but it's actually a really exciting new area in medicine. And it has, I think, really significant potential impacts for the future of our world, not just strictly related to, say, medicine, but I think it has potentially serious impacts that in your lifetime will become really dramatic and obvious. So this walk that we're going to go through today has 4 fundamental waypoints. And I hope everyone can read this, but there are 4 fundamental waypoints that I plan to take us through. In the first one, I want to introduce us to what transplantation, rejection, and what the statement of the problem is. And in the second waypoint, we'll look at how addressing this problem has some potential impact on our world. We'll take a look at how we took an approach to attacking the problem at hand. And then we'll look at the team that we formed to do this rather large multi-year project. And then in waypoint 3, we'll look at some of the results. So this is work that has largely been executed to this point and has shown enough promise to be an ongoing set of projects that have kind of split off and gone in their own directions, all carrying forward a piece of the project that we really wrapped up in 2013. And then in our last waypoint, we'll take a little bit of a look at where we go from here. In particular, some of the more exciting things about, for example, non-invasive sampling of cytokine levels and things like that. So, with no further ado, let's go ahead and get to our first waypoint, which is transplantation, rejection, and a statement of the problem. Now, I hope everyone is familiar with the term transplantation, but just in case, transplantation is the general process of taking an organ from one body and moving it into another body surgically. This is usually, the reason for this is because there is a damaged or missing organ in the recipient that needs to be replaced in order for life to be sustained. So transplantation is actually a relatively recent advance in medicine. Not even so much as 30 or 40 years ago, it was extremely exotic and even widely considered to be essentially an impossible procedure. But in the 50s and 60s, some initial successes were found, but very difficult to duplicate. Only in the 80s did transplantation really become a widespread, clinically accepted practice. And only in the recent time of, say, the 2000s, the late single-digit 2000s and up through now, was the control of the immunology sufficient for transplantation to become an actually reliable standard practice of medicine with 1-year survival rates in excess of 96%. Okay. And historically, cadaveric organ transplants were the predominant thing. So someone is out skiing, which by the way is one of my favorite pastimes, or riding their motorcycle. I bring these 2 examples up because in both these cases it's an inside joke among doctors that these are the 2 #1 pools of organ transplant, of organ donors. So the 2 largest pools of organ donors come from skiers and motorcycle riders. Of course, there's other pools of donors. But recently, innovation has made it possible for transplants to be executed between 2 living pairs of people. Say taking part of a liver or taking a single kidney and transplanting it. And that has led to an increased number of transplantations in solid organs. But the real bleeding edge transplantation medicine now is what's called vascularized composite allotransplantation. And this is essentially the process of taking an entire hand, a full limb, an entire hand has been the most common transplant. A full face, for example, and transplanting it onto another person. So far, the #1 population of recipients for this type of work or for this type of procedure have been United States military veterans. We have an extremely large number of, unfortunately, disabled veterans from our campaigns in Afghanistan and Iraq, numbering in the tens of thousands, most of whom are missing, most of the injuries are missing hands and legs, limbs of some sort, or severe facial deformation. So this has become a very important area of interest to the government as well. And so far, the history of vascularized BCA, I'll just say for short, has been about 80 hand, forearm, and arm transplants in 54 recipients. There have been a few faces as well, but the faces are much less common, only numbering in the single digits. The hand transplants are really kind of the paradigm in which this is being pursued and explored. And unfortunately, not 100% of these hands have been successful. The one-year survival patient rate, the one-year patient survival rate was 96%, 5 years at 93%. 1 year of graft survival rate is 85%, 5 years at 80%. So we're not out of the woods in terms of making this a perfect procedure, but it is a growing area of investigation. And as far as a small timeline, to give you a sense of the history, just how recent this field is and how quickly it's accelerating. The first double hand transplant was executed in 2000. And the first quadruple limb transplant was only just executed a couple of years ago. Quadruple limb meaning 2 hands and 2 legs. Usually the transplant occurs right here, just about the mid-forearm area. And in the legs, usually the transplant occurs right about the mid-shin area. Leg transplants are actually extremely rare. There's only been a couple done because the mechanical stresses on the leg induce what we call rejection more frequently than they do in the hand. But we'll get into that in just a second. Now, why concern yourself with this, you may ask, in this area? Well, one of the reasons, and I'll take you through a little journey as to why this is so important, but I think we must come back to the human nature of injury and healing and say someone is missing an arm or missing both of their arms and they cannot function. Imagine what your role in society may be if you had no hands. Imagine what your role in society would be if no one could look you in the face without cringing or averting their eyes. This is a tremendous debilitation, and it calls for some solution. Otherwise, we condemn the people who are suffering from these conditions to isolation, and they become dysfunctional parts of our society. So here, let's just take a look at what can be achieved. This is a double hand transplant patient, approximately 6 months after transplant. And this is what he is capable of doing with his transplanted hands, approximately 6 months after transplant. And of course, hand transplants, I hesitate to say obviously, but obviously are cadaveric limbs. So finding donors for double hand transplant is particularly tricky because you need to match all of the different things, not only tissue type and blood type, but tissue color, size of the hand, musculature, nervous system aspects. A lot of different parameters come into the matching process. But when properly done and properly cared for, and when diligent physical therapy is followed, 75% of full hand range of motion is possible to be restored in the hands within 6 months, which is pretty remarkable. Okay. So there's a dark side to this story, however, and the dark side is rejection. Rejection is the body's immunologic response to foreign invaders. And when you get sick, the body's immune response in terms of attacking these foreign invaders and destroying them is extraordinarily helpful. I'm very grateful for that particular response at this moment. It just saved me from dying last week from some kind of illness, right? But in the process, when we want to move body parts between people, and as in the case of transplantation, rejection doesn't have a switch where we can just tell it to turn off. And rejection initiates for transplants that we want to engraft properly, and it becomes a major problem. And what happens is it ends up killing the transplant. So in order to, and this is universally true, the only type of transplant that can be conducted between human beings without immunosuppression is an organ transplant between identical twins. This was actually the first kidney transplant that was done by Joe Murray back in the 50s. And he was able to complete this first kidney transplant and claim success largely because of the genetic quirk that the two immune systems of identical twins are identical and therefore don't reject when you swap organs between them. But everyone else on the planet will reject an organ if they get something from someone else because of major histocompatibility type mismatches. So it kills the transplant. So what you have to do, you have to suppress the immune system sufficiently so that the immune system lacks the power to essentially digest your new organ. Okay, so we want to get rid of rejection by suppressing the immune system. We do not want to suppress the immune system too much, and we'll come to that in a moment, because over-suppressing the immune system essentially is like giving you a severe version of AIDS, or it severely immunocompromises you and you become susceptible to all sorts of nasty infections. So rejection itself is graded in the current criterion, by current standards, according to the Banff 2007 criterion. This is particularly for skin rejection, which is particularly relevant for VCA. And it goes from grade 1 to grade 4B. Grade 1 and 2 you can call early rejection. Grade 3 is essentially what I would call more clearly expressed rejection. That's when it becomes visible to the naked eye. And grade 4A and 4B are essentially advanced levels of rejection. It should be noted that something like 2/3 or 3/4 of all grafts that reach stage 3 level of rejection cannot be rescued by increased steroids or immunosuppression. So if you hit grade 3, you're essentially better, or your odds are you're going to lose your graft, whatever that graft may be, hand, kidney, liver, etc. Now, there's a problem in here, which is that grade 3 is exactly when rejection becomes visible to histology. Histologically speaking, normal skin grade 1 and grade 1 rejection are almost indistinguishable. Grade 2 rejection, it's very, very difficult to distinguish from normal skin. Grade 3, it's easier to distinguish. But that's the moment when it almost becomes irreversible. Now, what does rejection look like? Well, rejection has some really obvious features when it comes to the skin. Lesions, redness, swelling, erythema, a whole variety of different conditions. And in these pictures, you can see some actual hand transplant rejection cases as they express. And these are in the graft. Now, rejection actually is a very fascinating process, because when you transplant any part of your body into another body, you have what are called passenger leukocytes. You're actually transplanting a part of the donor's immune system into your immune system as well. So if the volume of tissue is large enough, or the particular load of passenger leukocytes is large enough, you can actually create a weird situation where the donor organ rejects the host, and the immune system from the donor begins attacking and destroying tissue in the host, recipient. And that's what happens in this particular case of bullous pemphigoid in one VCA patient. And here we can see that the graft doesn't look bad at all, actually. It looks rather well. But the rest of the patient is unfortunately undergoing a rather aggressive subdermal immune system disorder that is directly caused by essentially the graft immune system rejecting the skin tissue of the recipient. These kinds of episodes, the only thing you can do is execute massive bolus doses of steroids and hope to rescue, keep your fingers crossed, and hope to rescue the patient before the immune system reaction cascades out of control and results in what's known as graft versus host disease. And GVHD is possibly one of the worst ways to die you can imagine. So rejection in skin can also be triggered not just by immunologic events, but it can also be triggered by mechanical stress. And this is actually a really interesting discovery that was made recently. This particular case of of rejection in a hand was caused by carrying a Christmas tree. And the Christmas tree was just a little bit abrasive, and it caused some small inflammatory events in the dermis of the skin. And those small inflammatory events cascaded up and actually induced a rejection event. So a non-alloimmune event led to a rejection event in this particular case. So this is what rejection looks like, and this is what we don't want to have happen. Okay. Now, before I go on and describe a little bit more about where we're going with this, I think it's important to give a little bit of a definition. Contact hypersensitivity is not rejection. Contact hypersensitivity is essentially an allergic reaction. And the reason I'm defining this term right now is because we use contact hypersensitivity as a control model. Contact hypersensitivity looks like rejection, but it's not rejection because it's not an actual full immune response based on histocompatibility response. So one of the major questions we want to answer is, can we tell the difference between non-specific inflammation and rejection-associated inflammation using our computer models? And so you'll see this term contact hypersensitivity in some of the groups. So we want to, I hope the picture is becoming clear as I go through this. What we want to do is be able to identify when the onset of rejection occurs so that we can apply immunosuppression to the patient at an early enough stage that we can avert the further development of rejection. If we can do that, then we can do a lot of things. We can transplant a much broader base of organs. We can administer less immunosuppression overall because we can essentially keep an accurate monitoring diagnostic of how the patient is actually responding to immunosuppression. I mean, essentially the whole world becomes more opened up. And because we administer less immunosuppression, it will vastly improve the quality of life of patients, because then their natural immune systems can remain more robust, and they can fight off infections. They can fight off infections of opportunity and other things more robustly, and therefore have to visit the hospital less. So what we want to be able to do is detect rejection early, so we can administer therapeutic intervention at a minimal level, at the maximally early level, at the earliest possible point. Right? But the problem is, if we can only visually detect rejection at grade 3, which is when it becomes histologically visible, that's not early enough. So we need to be able to detect it in grade 1 or 2. Now, I might ask if there were any histopathologists or transplant pathologists in the audience. Are there, by chance? No, okay. If there were, I would ask them to try to differentiate in these slides the early rejection versus the contact hypersensitivity response. Contact hypersensitivity, you do not need to treat with immunosuppression. Early rejection, you do need to treat with immunosuppression. Being able to tell the difference between the two is very important for pursuing the correct form of treatment. Okay. And so the point of this slide here is to simply show that there is essentially no way to visually tell them apart. The location of the infiltrate, the arrangement of cells, the density of the tissue is the same in both early rejection and contact hypersensitivity from a histological point of view. So we can't use it to make this distinction, so we have to go to something else. Now let me just reiterate that immunosuppression is highly toxic, and I think a lot of people don't understand how toxic it is. Immunosuppression as a form of therapy is only tolerated because the alternative is death. That is the only reason it's tolerated as a medicine. Immunosuppression, the #1 indication for patients receiving immunosuppression, the #1 downstream outcome of patients receiving immunosuppression is kidney failure. If you go on to any kind of high-dose immunosuppressive therapy, you're almost guaranteed to need a kidney transplant at some time down the street. So we don't want to use a lot of immunosuppression, and unfortunately the current clinical standard requires large doses of immunosuppression. So What we can do right now, as the current clinical standard, is measure but the level of rejection histologically, detect it in essentially a 5 to 10 day lag time, realize that we're on the borderline of irreversible rejection if we do detect it, and then immediately hit the patient with large doses of immunosuppression or steroids. And the problem with that is it creates damage. The immunosuppression itself creates damage. And that doesn't necessarily guarantee a rescue. Now, that's not a very good incentive to use less immunosuppression in your patients from the very beginning. So unfortunately, the current way of doing business with managing transplant grafts encourages encourages doctors to systematically over-immunosuppress their patients. The penalty for rejection is extremely high. The penalty for over-immunosuppression is high, but not nearly as high. The penalty for over-immunosuppression are a lot of hospital visits, maybe some morbidity related to opportunistic infections. So systematically speaking, the entire medical community over-immunosuppresses transplant patients, and that leads to lower quality of life. But lower quality of life is not as important a metric as graft loss and patient death. So this is what we have to try to overcome. Now, the way we're going to try to overcome it requires a lot of advanced analysis, and you might say, well, why do we have to do all this advanced analysis? And the reason we have to do it is because the immune processes involved are staggeringly complex, and we'll see why in just a minute. So simple analytics isn't enough. And the reason simple analytics aren't enough is because essentially the particular way in which the immune system responds to immunosuppression is different for every individual. This might surprise you, given the number of transplants conducted in the world today, but there is no metric for measuring your particular immune systems, or the particular effectiveness of any dose of immunosuppression on your immune system. There is no way, there is no method of measuring how suppressed your immune system is on any given immunosuppression. The only thing doctors go by is essentially what's called the trough level, which is the steady state amount of immunosuppression in your system at any given time, and connected to whether you're experiencing any events of rejection. So it's really almost like you're flying blind as a physician in this space. So, and by the way, the other major reason that there is extraordinary levels of complexity is this particular term, pleiotropism. And what that means is that the effect particular cytokines and chemokines have in the immune signaling process are highly redundant and are rated by affinity. So if, say, one cytokine binds to a particular receptor, then there's going to be a redundant backup cytokine that also binds to that receptor, but just binds to it with a little less affinity, so that in case the first cytokine weren't available, the message would still get through, but through a backup mechanism. And so this level of overlapping redundancy and multivariate complexity makes simple analysis essentially useless in this particular domain. So what are we ultimately wanting to do here? We want to balance the scales. We want to find an optimal balance between morbidity and rejection. We want to give patients the minimum possible immunosuppressive dose at the, and only at the essential times in order to balance a patient's physiological processes so that they're not rejecting, but they're not over-immunosuppressed. And this maximizes quality of life and essentially length of life as well. Okay, so here we have essentially a clearer statement of the problem. Modern medicine has excellent means of sampling markers, of quantifying those markers, and has excellent therapeutic agents for controlling rejection once it's been detected. But what we don't really have is a good way of assessing rejection, to know when to use the tools at our disposal. That's the hole we want to try to fill, okay, with this work. That's the hole we sought out to try to help to fill. So let's go through our second waypoint now. Let's talk about what the potential impact of addressing this problem will be, and I'll go through this a little bit more quickly so that we can get to the results and everyone can see what we actually have been able to do. But if we were able to actually solve this problem or help in any way to solve this problem, we will improve clinical outcomes, meaning we'll improve the quality of life of patients, we'll improve the length of engraftment, the length of graft survival, we'll improve the length of patient life, we'll reduce the total amount of hospital visits by transplant patients because they'll have less infections of opportunity. Okay? Will reduce the financial burden on the medical system. Transplant has come a very long way, very quickly, for being such a new medical procedure in terms of becoming a major burden on our financial system. We can see how many transplants have been done. Just in 2011 alone, 16,000 kidney, or closer to 17,000 kidney transplants were actually done. Liver, heart, lung, etc. And so if we just run the numbers, and this is according to US government statistics, just the estimated annual US spending on immunosuppression drugs alone is about $582 million and growing. Right? If we were able to cut the amount of immunosuppression that patients needed by optimizing their medication strategy by 60%, and there's a lot of reason to believe that you can actually cut it by far more than that, you could save hundreds of millions of dollars per year overall in the medical system. And then, of course, last but not least, science, right? We want to advance our understanding of how immunology works and how the human body works. We want to advance our understanding of the field. So let's look at the approach. We have a few basic hypotheses that we outlined to essentially say, here's what we're going to hypothesize and here's what we're essentially going to try to confirm in order to reach this objective of finding a way to measure and attenuate, measure rejection and therefore attenuate our therapy of it. Our first hypothesis is that we can, in some way, actually detect the onset of rejection before the current clinical gold standard. Our second hypothesis was that somehow immune signaling patterns must drive rejection, and that these immune signaling patterns must be distinct within each tissue. The reason we thought that is because each tissue, just by its very nature, kind of an obvious point, is comprised of different cells, and different cells signal differently. And then we thought that finally we should be able to distinguish different types of inflammation associated with the immune signaling patterns associated with different types of inflammation. In other words, rejection isn't just the same physiological response as, say, allergy or as, say, nonspecific inflammation of another type. Okay? And so what we decided that we would have to do, because no comprehensive data of the type we needed exists, we would need to do a very large-scale small animal study. And so we used a rat model in all of our experiments. And the reason for that is because the immune system of the rat is extremely close to the immune system of the human being, so almost all of it can be conserved. And so what our basic approach was is we transplant legs, full hind limbs, hearts, lungs, kidneys, spleens, etc. We then collect samples and quantify the cytokines and chemokines from those samples. We then analyze them with our pattern recognition models for any kind of patterns that are of interest. And then we would iterate in our next round of experiments to collect more samples of the particular groups that were just displaying patterns of interest. So in particular, for example, we didn't have a waterfall methodology. We did not define all of our groups and time points right up front. We essentially said, let's try a range of them, do some experiments, see what the results look like, and then in our next tranche, we'll try more of the ones that look particularly interesting. And in that way, we're able to make maximal use of our resources. And small animal studies, for anyone who actually has done them, are very expensive, so it was important to try to optimize our money. So, for anyone who aren't familiar with this, cytokines and chemokines are essentially the messengers of the immune system. They're integral to the immune response, and essentially every single cell in the body emits some form of these proteins, some form of these chemical messengers. And As I said, they're pleiotropic, so they frequently cross-bind. And really, what they are is essentially the information superhighway of the human body. They are the communication system that essentially signals and coordinates all of the state and activity of the immune system with each other, or particularly of the cells of the immune system with each other. And if you just take that at face value for what it is, then it's a small logical step to say that they must contain the information required for us to reach our objective. Right? So we formed a team to investigate this. Initially, the way this started was a little bit funny. I walked up the street to UPMC, this was back in 2008 or 2009, a while ago, and met with Stefan Schneeberger, who was kind of a wunderkind Austrian surgeon who's done many of these hand transplants, some of the original ones in Europe. And we sat down and we talked about this, and we really essentially hatched this concept together and decided that we would recruit and bootstrap people onto this project as aggressively as we could, and it eventually grew to include everyone on this list from the various centers here. And in particular, the reason there's so many MDs up here is because we had to do many hundreds of surgeries. And even though I will say it was a delight to become educated and trained in microsurgery, and I actually completed several of these island transplants myself, there was no way in hell I was going to be able to do the amount of experimentation required. So we had to farm the work out amongst a large group of people. So this brings us to our third waypoint, right? How can we actually predict rejection? And so let me walk you through what other people have been able to do. Other attempts in this area, and this is not a new idea. It's a relatively new idea. We aren't the first people to think that this might be a really great thing if it's possible. But we are some of the first people to get really good results. Other people who have tried this have, for example, only got 62% level of accuracy in kidney transplant cases. Here they got great sensitivity in using Doppler tissue imaging, but really poor specificity. And in fact, unfortunately, Doppler tissue imaging is not a leading indicator, so that didn't really actually give you any kind of predictive power at all. Oh, you mean, go ahead.
So that's a problem, is binary classification. Is that predicting rejection or not?
In these cases, yes, it's just predicting rejection or not, at an early time point, at a specific early time point. And then, now the one that I really like and I'm excited by, I mean, I don't like it as much as what we did, but I really like it, is this one, where a group actually demonstrated that it is possible to detect rejection of heart transplants using nothing but a breath test. And that actually, with some additional advancement and development, could actually turn into a really promising approach. So the problem hasn't been solved by somebody else, so we decided to proceed. So what is our methodology? We capture data by actually doing the transplant, taking samples. We then quantify the cytokine using a Luminex machine, which is a high throughput advanced machine that essentially is able to quantify all of the cytokines present in a sample at any given time. These machines are capable of quantifying hundreds of analytes per sample. We quantified 14. And then we prepare the data for analysis. Then after we prepare the data, which actually has become normalized, we analyze the data, and then we try to derive our key insights, targets, and conclusions. So that's essentially the process that we just went through, right? Or that we go through in this research. This should give you some sense of the scale of the study itself. Our surgical groups were of quite a large size when you consider the number of animals involved in the study. And each of them was intended to elucidate a particular aspect of the question that we're asking. And here are the features of our analysis. And since everyone in here is probably more computationally oriented than biologically oriented, this is probably of particular interest. Our features essentially were, in their original raw state, a matrix of 14 features. And the features were essentially the concentration in picogram per milligram of protein of each of these 14 cytokines. Now, I won't go through the specific function of each of these 14 cytokines, but remember what I said earlier, that all of them have very complicated overlapping fields of effect and have multivariate interdependencies between them. So, what we then did is we executed a series of feature transformations on the original sets of cytokines that we had and tried to grow them by teasing out diagnostically beneficial feature interactions. And so how did we do this? Well, we went through a process of consulting expert knowledge in the form of literature from PubMed, and then also just some kind of raw numeric experimentation. And what we found was that there are feature interactions that are extremely beneficial to the process of classification, to the accuracy of classification. And so right here we list the 4 that were particularly helpful. And I have a graph that I'll show you in terms of how much they really helped. And so our final data set was, our final training and analysis set was a matrix 18 features wide, essentially. Okay. Now just to give some sense of what these, of the feature transformation, and I really like to emphasize this point because a lot of times I work with some folks and I talk with students and they don't fully understand the utility of feature transformation or what intuitively it really is supposed to do or help you with. And what feature transformation really is supposed to do is give you a new perspective on things in your data without violating the integrity or the validity of the data itself. Almost like rotating something in space. So we did PCA on our original data set, and we found certain cytokines were extremely important, and other cytokines were essentially totally irrelevant in terms of PCA. Now, what is PCA measuring? Remember, PCA is essentially measuring the contribution of variance of each of these features to the whole system. So the longest lines are essentially the cytokines that are responsible for the most variance, right? So you should be able, using your synthetic PCA variables, going from most important to least important, reconstruct the variance you observe in the actual measurements themselves really effectively by using essentially the way the loadings represented here. Now, but that's not really the whole story, and PCA is often treated as kind of like this really a magical thing, and I agree, it is kind of a magical thing. But this isn't actually very helpful in many circumstances when it comes to classification. PCA is telling you which of your features are contributing variance to the system behavior that you're observing. But that isn't necessarily the same thing as helping you determine how to best separate your groups from each other. So I turned to a different feature transformation method, which is multivariate analysis of variance. Multivariate analysis of variance. And in this, what we can actually see is that we have an almost completely different set of cytokines that were brought up as maximally contributory to the synthetic variables that MANOVA generates. Now, what is MANOVA doing different from PCA? MANOVA is in the same family of methods as PCA, but what MANOVA seeks to do is actually create synthetic variables that maximize the separation of groups. So instead of maximizing how much variance is captured in each of the synthetic variables, what MANOVA is trying to do is maximize the amount of separation between the labeled groups that you can achieve in the smallest number of synthetic variables possible. So boiling that down, what it really means is that these particular features are going to be more helpful. These particular cytokines are going to be more helpful in separating your groups from each other than the other cytokines that don't have high scores. Okay. And so let's take this down, and I'd like to involve you guys in a little experiment. Because really it's all about perspective. I mean, I think a lot of us, and myself included, get into the mathematics and get into the equations and get kind of really into it. But you have to realize that take a step back and understand the intuitively what the mathematics are trying to help you do, right? So here we have two objects. These two objects are the same object. So what object is this? Does anyone have? Huh? A cylinder. Okay, excellent. Very good. You got the answer correct, right? So we have essentially a cylinder. So if we are measuring some system behavior and we get in the abstract the equivalent of a circular behavior, we could be completely misled as to what we're actually seeing, just because we happen to analyze it from a certain perspective. Now, if we took measurements of the same exact system using different instruments or coming at a different time point, right, we might get a square perspective on the same exact thing, or rectangular perspective. And again, completely mischaracterize what we were actually observing, not because we did the math wrong, or not because we somehow lack insight, or are, have failed the obvious, but simply because we are being misled by our perspective. So what I found is exceptionally important when interpreting and analyzing these complex systems is to try to, however you can, rotate your perspective on the system's behavior. Look at it from its original raw set of features, look at it from transformed sets of features, do basis expansion, do everything you can to observe system behavior under alternate conditions. Let's try this again. This particular one, I think, might be a little bit more challenging. So we have a circle and we have a wave. Oh man, okay, we're too smart in this room. Yeah, it's a spiral. I guess you could possibly call that a spring too, right? So in this particular perspective, the difference between a circle and a wave, again, is just a bit of parallax. Right? So this is why, in my opinion, the feature transformation is so useful and helpful. And so what we try to do is we try to incorporate the feature transformation into our workflow, and essentially say, well, the MANOVA set is telling us what features or what cytokines are particularly helpful from a diagnostic perspective, because they seek to create separation amongst the groups.
So is the MANOVA supervised?
Yes, it has to be.
PCA is unsupervised?
Yes, PCA can be unsupervised. In our case, it was, and the MANOVA was supervised. Absolutely, right. You have to have the labels in the MANOVA transformation in order for this group separation to occur properly. Right. So, again, the MANOVA might help with a diagnostic development, and PCA may help with therapeutic targets. That was the basic idea here. So let's go ahead and let me skip to some of the results. Well, we did a couple different types of analysis. We did some baseline analysis because we didn't want to just say, okay, we're able to classify and win, let's all just go home. We wanted to understand kind of a range of performance here. So we said, okay, we'll go with really simple classifiers, and then we'll do some little bit more advanced classifiers, and then we'll do some really advanced classifiers, really being a relative term in this room. Okay. So this is our baseline set of analyses, which include linear discriminant and quadratic discriminant analysis, essentially as kind of the methods to beat of the simpleton variety. And then we do some more advanced analysis, particularly essentially the random forest or the bag of trees being our kind of go-to ultimate method. Right. And so let's take a look at what histology is able to do. So now we're into the actual results, okay? With all of those groups across the whole study that I just showed you and discussed, here is the performance of a transplant pathologist, a very good transplant pathologist, by the way. 2 separate transplant pathologists, one right up here at UPMC, one at the University of Innsbruck, okay? And here is essentially their grading. And what we see is that it's a complete failure to detect early rejection. And by the time rejection is detected, according to histology, it's already in an advanced stage of rejection. Okay, so the results are histology does essentially what we thought it would do, which is not really help. So in this particular case, now what we're looking at is the result of essentially classifiers attempting to differentiate tissue. The first simple question we asked and thought would be interesting to try to understand the answer to is, can we simply tell apart muscle versus skin tissue? I'm sorry, allograft versus isograft? And the answer is essentially yes. And then what we found is that actually with enhanced performance, we're actually able to do an extremely good job at differentiating tissue. Okay, but this isn't really the first question that we came in to answer. This was really just a sanity check. Are we able to tell some important things apart? Okay, and so let's go ahead and get to the detection of early rejection. What we found was that essentially, by random chance, we have this level of performance. Then linear discriminant and quadratic discriminant were each able to do slightly better in terms of detecting rejection, early rejection, grade 1 or 2, in the blue in skin and the red in muscle. And here, what we found is that what we were able to do with the random forest, rightmost here, in terms of our early detection of rejection in skin and in muscle. Okay. So the short answer is those features, combined with that algorithm, does a good job of detecting rejection before, at a time point where histology is unable to detect it. Now, to take a closer look at it, we did a receiver operating characteristic curve to try to characterize the performance a little more precisely. And what we found is actually the 95% confidence intervals are really good, really tight around this particular result as well. Now, what we're finding is that actually it's easier to detect rejection in skin than in muscle, and that leads to some interesting downstream hypothesizing. But skin is really an epithelial tissue, and epithelial tissues are the danger tissues. They're the tissues that tend to reject the most virulently and earliest. So that's actually okay. It's a reasonable bifurcation. And just for your entertainment, these are projections of the first and second canonical variable of the Maynova transformation, showing that in fact there are significant differences in terms of the synthetic variables that Maynova captures, even in the first 2 dimensions. So the next question is, can we identify inflammation type? Well, again, our random chance and our QDA and LDA perform at certain levels, not that great, honestly. And what does rejection, by the way, let's just say, what does inflammation look like? I'd like to just show you a quick picture of this. This is in one of our rats. I think you can tell, essentially we have in the foot pad a situation where we have rejection, early rejection, and then we have rejection at postoperative day 5. POD5 means postoperative day 5. At postoperative day 5, you're really dealing with grade 3 rejection. So this is essentially grade 3 rejection. So we can have a visual of what we're talking about when we talk about these things. But what we found is that actually we can separate the type of inflammation, meaning contact hypersensitivity or unspecific inflammation, from inflammation specifically associated with rejection at this level of performance, 89 and 81% in skin and muscle respectively. And so not only can we detect rejection early, but we can actually be rather specific about whether what we're detecting really is rejection versus specific inflammation. And again, here are the ROC curves showing the 95% confidence bounds on that result. Okay. So let me go ahead and skip forward a little bit because of time considerations and talk a little bit about our extension to solid organs. Now this is a little bit less thorough than the composite or the vascularized composite VCA results. But what we found was actually that the random forest actually is extremely good at detecting rejection in the heart and in the lung model as well. So this is not just a skin and muscle specific result. This works in the heart as well, and this also works in the lung. So for anyone who really wants the details, This is our best model. And this is essentially our confusion matrix for the early detection of rejection. And further analysis is ongoing. Yes, please, go ahead.
What's the depth of the decision trees in the forest?
The depth of them. So they were grown out to maximal depth. And the actual depth that they were grown out to was something in the neighborhood. I'd love to give you the details more specifically, but just recalling off the top of my head, I want to say that they probably had something in the neighborhood of 30 layers.
Wow.
Of depth.
That's quite surprising because typically with the linear models, but basically I can see a huge difference between this LDA and this forest, and even the decision tree is a big jump. So that means the non-linearity is there. But then you have the 30 depth. So that's really a more complicated interaction between those features.
It's extremely complicated. The thing that really shocked me, in a pleasant way, I'm very happy to say, is the depth and complexity of the trees, given the stability of the actual confusion matrix result. These are very deep, nonlinear interactions, but across a wide variety of sample types, they hold up. They don't seem to be overfitting too badly.
Right, but still, that's not some phenomenon we typically see with the text analysis. It's probably a problem.
Well, and it's certainly something that we're looking further into, is why these particular 7 didn't fit with the rest of them. You know, the error analysis is ongoing, but essentially there are certain situations where the immune system of the animal behaves atypically, and this is true for people as well. You have, and now I'm in the realm of speculation, so let me very explicitly say I'm now speculating. But you have situations where people might take a medication or be exposed to a certain stimulus, and they will have a paradoxical effect. Right? Or they may have a less than acutely effective effect or a hyper effective effect. And what all the factors that add up to creating those kind of variances in our experience are certainly the same factors that contribute to the error here. Now, exactly what those are is probably something that we won't know for a while, because there is more unknown about the immune system at this point in history than known. So we're really, this is one of our first attempts to breach a rather simplistic paradigm about how the immune system works, and look at its function from the perspective of modeling its communication matrix, which just hasn't really been done extensively before. But what we can say, without any doubt, is that the level of complexity of the signals that the immune system is conveying to itself are extraordinarily complex and stable and rich in information. Now, this is for muscle. And as we can see, we did not do as well in muscle. Muscle is more complicated than skin. This is actually an interesting kind of paradox. Skin is more immunogenic, has more immune system activity, has, by all accounts, the harder rejection reaction. Muscle is the more difficult to differentiate. And so there's an interesting puzzle that we're continuing to think through. Just to give you also a sense, I told you before how much the feature interactions helped. The feature interactions were essentially the difference between getting 90 and 95% accuracy, or getting something like 82 or over 90% accuracy. So the feature interactions are very helpful. We only are capturing 4 feature interactions in this particular analysis. Something that we're continuing to look at is a more systematic way of doing additional feature interaction exploration. I personally think that we will be able to do much better in the future by capturing other feature interactions and by measuring more cytokines. So the particular cytokines that we identified as being the most promising for building a new diagnostic for rejection are these. So I'm very happy to report a concrete outcome. If there is anyone from J&J or Anyone thinking about a biotech startup in here? My gift to you. These will let you build a new diagnostic that will help you detect rejection. And why stop there? We've also identified, and this is not just my opinion, this is not just the computer's opinion, this has actually been reviewed by some of the best surgeons that I know, and we all agree that there is really good and substantial reason embedded in the literature for these particular cytokines to be important. And these, we believe, are going to be the best therapeutic target ligands and receptors for interrupting the rejection process and essentially providing a more effective version of immunosuppression without the toxicity of the chemical immunosuppression agent itself. Yes. Cyclosporin and tacrolimus both are general immunosuppressants. Yeah. Okay, now some really important caveats. We measured these 14 cytokines because that was what the Luminex catalog allowed us to measure in an economically feasible way. These were essentially 14 of the usual suspects of cytokines involved in inflammation. These were not the optimal 14 by any stretch of the imagination. If we had the money and we had the resources, we could go back and design an even better panel than what we have today. The feature and action space is hyper-rich, and we really didn't do it justice in terms of fully exploring it. That's something we want to continue to do. And of course, the human population is much more complicated than the rat population, and so we need to do further investigation in terms of gathering data in order to make real generalizations. Now, it's been productive. This is a little bit dim, but about 6 papers have come out of this so far, and 5 major conference talks. And we're continuing to produce papers out of this work. And some of the most important support has come from a variety of sources. And you'll notice that actually the majority of the money for this work has come from the Air Force. And a lot of you may not be aware, but the United States Air Force is responsible for running the forward field hospitals in all of the theaters of campaigns in Iraq and Afghanistan. And so the Air Force, when a soldier comes back with no hands, that's the Air Force's problem. And so they really do want to see progress in this domain. And then, of course, in particular, we had a Pennsylvania Department of Health grant that was very helpful, and an international collaboration with the took me a long time to figure out how to pronounce that term. So just in final wrapping up, I love my quote from the quintessential madman, Salvador Dali, but let's take a look at exactly where this has been able to go from here. We did an additional follow-up study on analyzing whether we could detect this same type of rejection non-invasively. For all the stuff that I've just shown you previously, you have to take essentially a 4mm biopsy of the tissue. You have to cut a little piece of tissue off or use a little needle or something like that to pull some tissue out. And this is not very desirable because you can actually create a rejection response just by taking the sample. So you don't want to have to do that. So what we developed was a non-invasive method where we use essentially something called Cebu tape or desquame. And these are actually little pieces of Scotch tape, and you just put it on your skin, leave it on for a minute, and peel it off. And then you put it in a solution and dissolve it, and all of the little sebum oil and cytokines that were on the surface of your skin get into the solution, and then you can analyze that for cytokine contents. Right? So it's not invasive. And here's the result for the detection of early rejection. The signal clearly is highly attenuated now, coming through the skin, but it's a heck of a lot better than I thought it would be. What we have here is actually a really promising preliminary result that shows we could go, if we had more resources, down the path of investigating what the optimal non-invasive sampling markers are. And so where we want to go from here is to translate the findings. We want to do a lot of things, a lot more than listed on this slide. But in particular, I think using this information to help understand the immune system better with in silico models. Going an additional step in developing a breath test for rejection would be really wonderful and very much within reach in these results. And then I'd like to disseminate this data and teach physicians around the world how to use this method in their clinical practice. I'll skip this slide, which is a more complicated answer to where we go from here that one of my surgeon friends gave me. It's too complicated, but essentially what they want to do is create a situation where they wean patients off of immunosuppression to the point where they get to either minimal immunosuppression or eliminate immunosuppression entirely post-transplant. That would be another endpoint from where we are. And then finally, I'll let this person speak for herself.
Go ahead, you're on.
Hi, Dr. Lee. I just wanted to say thank you and the rest of the team for everything you guys have done for me.
Tell them who you are.
I'm at the Millville Airport in New Jersey, getting ready to fly my plane.
Her hand that you saw in the foreground, that was a transplanted hand. She lost both her hands to septic shock and septicemia, and so she wouldn't be able to do that without a hand transplant. So, thank you very much for your time.
Questions?
Yeah, so we have very rigorous methodology, and of course all of the animal facilities are very rigorously controlled by institution animal control boards and such. No, they were all identically treated. All of them lived in identical little boxes, were fed identical food, sampled. And no Mozart, although that might have helped. No, they're absolutely correct. The conditions of the animal could certainly be a factor in their immune system behavior properties. And that's why maintaining an identical setting for all of them is important. You actually will just notice that if you get less sleep, your immune system is less effective. Right? And so we try to control for that as much as can. Yes?
So when you move from decision trees to random forests, you lose some of the nice interpretability.
Yes.
I was wondering, did you do analysis of what you learned with the type of forest that you learned, and how did you find that?
That's actually a fantastic question. And so I didn't have time to really get into another part of this, which was what I called the biological function analysis. And what we went through was a rather exhaustive process where we looked at the model results, we looked at what cytokine, and we looked at the feature transformation results, and we went to the literature, and we actually wrote some software specifically for this, which extracted entities, named entities, and identified the relations of these named entities in a matrix, and essentially attempted to find some biological reason why these particular cytokines might be expressing in the ensembles that they did. And then we would go through and essentially try to build some interpretation of our model results based on the biological information expressed in the literature. Now, in terms of trying to understand the actual decisions being made by the models themselves, we can, of course, you can pull any individual tree out of a decision forest and look at it and analyze it. The problem is it's particularly in work like this where there's so much new, it's very difficult to understand what you can really believe or what there's a basis for believing in your interpretation of the tree structure versus what is just a statistical fluke or a coincidence. So I would love to look more into the question of how do you relate the interpretation of the model results with what I would characterize as expert knowledge or domain level understanding of the subject area. And that's something that could involve visualization, better visualization, could involve more language technologies, but for which essentially we went through a very slow manual process of doing it by hand and just turning a giant crank. Does that answer your question at all? Oh, please.
It seemed like the success rate for these grafts was much lower for the rats than it was for the humans. Is that because the surgery is more complicated on a smaller animal, or is it because that biopsy is more dangerous when you try to take it on a rat?
No, it's because we were specifically causing certain rats to reject. Right, because we needed the data of rejection, and we needed the data of successful immunosuppressive treatment, and we needed the data of transplant but no rejection, which is an isograft, a transplant between two genetically identical rats. So the reason you had such a high failure rate was because it was part of the experimental design.
Okay. How is the rejection induced then? Do you like graft on a bad part, or?
No, so we, in there you might have seen, we have two different strains of rats, brown Norway and Lewis rats. And all brown Norway rats are genetically identical. It's like a whole population of identical twins, and all Lewis rats are genetically identical. So the way you induce rejection is you transplant a brown Norway leg onto a Lewis rat without treating it, and that will guarantee to reject. And to do no rejection, you take a Lewis rat leg and transplant it onto a Lewis rat.
Okay. So were all of the grafts then cross-breed type grafts?
Yeah, so allograft, I'm sorry, I probably should have defined this term earlier. In all of the work that I showed, allografts are mismatch, meaning they will reject. Isograft is a match, meaning it will not reject. Okay. Thank you for bringing that up. I apologize. I should have made that clearer. So there was a specific design in the experiment to try to get a large number of rats that would have transplants express all of the wound healing and inflammation associated with transplant, but not reject, so that we could differentiate that kind of inflammatory activity at an immune signaling level from the immune activity associated with rejection. And that was, in my mind, the greatest barrier. There's a lot of noise after you do a transplant. It's an extremely traumatic procedure. But there is something special about rejection that is not just the same as the trauma received by transplant. And that carrier signal, which is embedded in the immune signaling matrix, can be teased out by these random forest models on those features. Go ahead.
So, what do you think are the major challenges in translating this to the immune system? Because, I mean, particularly some of the PLRs, they don't exist in the human body, and if you give one of those, I think one of them was there in the findings.
So the biggest challenge in translating this to the human immune system is volume or number of samples. There are very few human transplant, composite transplants. So the way that this work, I think, might make its way into the human population is by going into an area of transplant that has more routine procedures like kidney transplant. And using this to try to diagnose kidney transplants early and work essentially minimally immunosuppressive therapeutic strategy out with kidney transplant. Kidneys just because they're so voluminous, but livers would also work. And then from there, migrate to something else. And eventually you'll collect enough data to really know what you're looking for. And of course that carries its own range of challenges because the kidney is not a hand. So you need to adapt for different tissue type. But I think that's a smaller barrier than just the problem of having no data at all.
So just to follow on this business of wonderful opportunity for transplant, we have a model that's not quite for the same thing, but contains the unique aspects that we need for either transplant or whatever the rare transplant is.
I think that's a fantastic point. If anyone does that, I'm all ears.